Well, really excited to be with you all today. As Derek mentioned, I am a UCSF professor. I clinically practice as a primary care clinician at San Francisco General Hospital, which is our safety net system. And that's the clinical lens I bring to my work as a researcher. I focus on digital health, health disparities, and implementation science. So I have no disclosures. And so what I'm hoping to cover today in the next like 50 minutes or so, and I'll be joined near the end by some of my colleagues from our safety net system as well, is I want to talk briefly about telehealth and how we think about telehealth's impact on the quintuple aim in primary care. Spend some time really thinking about the digital divide and sort of barriers to being able to leverage telehealth to improve primary care. And then I hope to close off with some takeaways about how we can make sure that telehealth actually improves equity. So as Derek mentioned, I'm going to just do a couple of poll everywhere questions during the presentation, and we'll just do sort of an easy one to get us started and get folks familiar with the platform. So as you can see on the top of the screen here, there are two ways to respond. I do find it a little bit easier to go to the website, so the pollev.com and then / it's Elaine C. Cohn. You can also do it through text messaging if you would like. And so it's a text message. You basically type 37607, so you're texting to that number, and in the text itself you put in my name, Elaine C. Cohn. And so would love to get folks sort of logged in and responding. Just making sure, and if folks are having issues, certainly let me know. And then once people are logged in, they will be able, perfect. So I'm seeing results coming in. I'm not seeing them on the screen, so I'm going to go ahead and scroll to the next slide and see how that. Okay, awesome. Great. So I'm seeing I'm missing a lot of what the others are. Would love if people feel comfortable sharing in the chat. Is the chat open to everybody? Okay, yeah. In the chat, if they could just would love to know sort of who's falling in that other bucket, or what other roles they identify with. Great, researchers.
And also, I think you're able to answer two. You can
multiple times. Yes, yeah. I made it so you could answer multiple times. You know, like a lot of experts, of course, also provide care. You know, folks wear multiple hats. Two is probably not enough hats. I'm sure folks wear lots of hats in the room. Great. Okay, so it looks like we've got a lot of folks who are really interested in telehealth and know a lot about telehealth, and folks with a lot of really direct experience caring for patients or thinking about sort of the patient experience. So that's great to hear. I'll give it, maybe another 10 seconds for answers to come rolling in. And then once you're logged in to this website, if you do it online, you'll be able to sort of easily respond to the other questions. The other questions sort of will pop up on your screen. Okay. So, we saw the results here, and there's a lot of folks that are maybe in the research hat and a lot of telehealth experts. Okay. And then next question here, I just want to get a sense, since telehealth policies are quite different, at least at a Medicaid level in different places. Want to know where most folks are coming from. Oh my God, sorry. I just assumed we go in the United States. I see one bucket is coming out of the United States. Okay, so it seems like primarily in Texas. We have looks like Kentucky here, Georgia. And then for those of you who dropped your dot somewhere outside of the United States, if you feel comfortable sharing where you're coming from, that would love to hear as well. We know that certainly practice patterns and payer policies are different internationally as well. Great, so lots of folks in Texas. I see somebody from California, Washington, or a couple of folks coming from elsewhere. Oh, Hawaii, great. All right, okay. So we'll appreciate folks' response. We'll go ahead and move on to the next slide, and then hope people will continue to stay engaged. So just to get us on starting on the same page, I want to just start off briefly with a definition of how I think about telehealth. I know a lot of people sort of when we think about telehealth, they think really primarily about sort of virtual visits, things that are here in the top left bucket. And what I like about this framework is that I think it helps us think a little bit more broadly about telehealth. So it is a 2x2, and along the left side here, you can see they focus on thinking about if it's provider to provider or provider to patient. And then along the top, it's thinking about distinguishing between synchronous and asynchronous types of care. And so virtual visits, I think, have gotten a lot of attention in last 2 to 3 years. But there's also asynchronous types of care, which actually have a little bit more data behind it, particularly between provider to patient. So in this framework, they talk about it as e-visits, but I think of patient portals here, remote patient monitoring in this space as well. And then there's a lot of sort of provider to provider telehealth programs that are not as well developed, but do exist as well. So for folks here, would love to think about when you're thinking about telehealth or your experiences with telehealth, what type of tools are you all using, or do you have experience with? And you should be able to, I think, respond 2 or 3 times in this poll, right? So seeing a lot of visits, some virtual consultation, some remote patient monitoring, patient portals, some e-visits. Great. It looks like there's really a diversity of services that being used at healthcare systems that you're at, or in whatever settings you practice or work in. Sort of overwhelmingly, certainly the video visits and audio visits. Excellent. Well, it seems like there's a lot of experience in the room. So hopefully we'll be able to draw on some of this experience and during the Q&A portion at the end. The last thing that I want to do, just to set some groundwork for our talk here, is really thinking about really what the goal of healthcare is. So I think the reason there's a lot of excitement in telehealth and digital health space is that I think, to be frank, we're not really doing a great job at reaching really the aims of healthcare, right? So we started with the triple aim, which is really focusing on patient experience, better outcomes, and lower costs. And certainly as we move towards thinking about clinician well-being and particularly health equity, there's lots of concerns about digital health. And so what I want to highlight in the next, first set of my slides are focusing on where we've seen telehealth to really impact any aspects of these, this quintuple aim. And then I'll focus in the next section really highlighting on the concerns related to disparities. And I'm going to focus primarily on chronic disease management because chronic disease care, really is one of the key cornerstones of primary care. And I want to get us all on the same page. So, I know there's some clinicians in the room, but, when we as clinicians think about managing a chronic disease, I think the healthcare system and clinicians in particular too are really focused usually on discrete clinical visits, right? Like that's what we reimburse for. That's the way that a lot of our healthcare system is structured. And so, a clinician, from the clinician perspective, what happens is, a patient comes in, they tell us what's going on, we do a couple of tests, we make an assessment, we maybe make some recommendations, and then the patient goes home, acts on those recommendations, they come back in and sort of repeat the same process, right? So it's really focused on these discrete clinical visits, and that's where we'd like to devote a lot of our time and energy in our staffing structure. From a patient perspective, it's obviously like very, very different, right? So the patient, they may feel unwell. Sometimes they feel fine, but the patient, may be feeling well. They decide they want to schedule an appointment, or they try to figure out, especially if they have a high copay, should I go in now? Should I go in later? If they eventually make it in, that's sort of when they interface with the clinician, and then they go home and have to act on the clinician's care plan, and that can really involve a ton of different, things, right? Medication adherence, diet and exercise, disease monitoring. There's a bunch of things that go into really that self-management part. And then eventually, the patient hopefully can come back in and see us if we're accessible, and then sort of go on and so on and so forth, right? So when we compare the patient perspective, right, these blue boxes to the clinician perspective, which is the white boxes, and of course the blue boxes are a really simplified version of the patient journey, we can see that there's they're quite different, right? And the healthcare system, unfortunately, has really primarily been very clinician focused on these white boxes. I think one way to think about where we can use digital tools to help with improving outcomes in chronic care disease is really to think about the chronic care model. So the chronic care model came out in the late 1990s for those who are less familiar with it, what it does is it talks about sort of like 4 key components of thinking about caring for chronic diseases. So clinical information systems, decision supports, delivery system designs, and self-management systems. And then these 4 components hopefully create a informed, activated patient and a prepared, proactive team. And then they hopefully have productive interactions and we have improved outcomes. And so this model is pretty old now, and it's been 2 or 3 decades, and it was pretty forward thinking at that time to really focus on sort of the patient experience outside of really the healthcare system. And so I want to first start off with highlighting places at this bottom part of the model and how telehealth can help with that. And so this bottom part is really sort of patient-provider communication, and really is, of course, the cornerstone of any high-quality healthcare. And the reason I think it's helpful to start with that portion is because when we think about the patient's journey to managing a chronic disease, there's a bunch of places where they probably would love to be able to check in with their clinician, and that's outside the office visit, right? So if they first feel unwell, like trying to figure out like, hey, is this worrisome enough that I should come in or should I stay home? If they're going home and trying to execute on a care plan, maybe they forgot exactly which medication they're supposed to take or how they're supposed to change their medication. And then also sort of figuring out like should they come in and schedule a follow-up, right? These are all points where it'd be really helpful, I think, from a patient perspective to be able to communicate with a clinician. And I think from a clinician perspective too, it might also be helpful as well to really make sure that when a patient is coming there to see you in person or even over a video visit, that they really actually need that sort of level of care. And what can be helpful for these points where patient may need additional touch points with the clinician is things that really go into sort of this asynchronous bucket with patient to provider communication. So in this framework, they focus on e-visits. I also like to put, patient portal messaging and remote monitoring in this space. And so I want to highlight first patient portals. So patient portals, I think folks are probably familiar with it. It looks like based on from that poll. But patient portals are usually associated with EHRs, and they're a way for patients to be able to log in, schedule appointments, message their clinicians, ask for medication refills. There's a variety of different services you can usually do on a patient portal. And what the data has shown is that for certain diseases, and diabetes in particular, there's been a fair amount of literature in diabetes, is that patient portal is associated with improved outcomes. So this study, which was based out of a group at Kaiser, what they looked at is whether or not people never used the patient portal. They whether they never used the patient portal, whether they had a computer access to the patient portal or computer and mobile access. And on the left is a graph of PDC, which is proportions of days covered, which is a measure of medication adherence. And what you can see is access to the patient portal, even from a computer only, improve medication adherence. And then computer and a mobile, if they also access it from their mobile device, they had an even greater improvement in medication adherence. And what's particularly noteworthy is the blue bar, which is actually those who had uncontrolled diabetes were actually most likely to benefit from accessing the portal. And we see a similar pattern on the right side, which is A1C change. So that's a measure of diabetes control, and you want that to go down. And so you can see that the greatest decreases in A1C are amongst those who had uncontrolled diabetes, right? So we can see here that patient portals use can be really helpful for improving clinical outcomes here, which is, of course, one of our aims. The other thing that patient portals can help with are certainly the care experience, right? So these are some quotes from a study that looked at, how folks felt about patient portals really pretty early in the rollout. So this is from 2013. And you can see this clinician at a safety net site in Alaska, they comment, well, if a woman knows she has a UTI before, it's the exact same symptoms, she's really glad she doesn't have to come in, to get assessed, to get the antibiotics. So this is really improving the care experience. And then this leader at a group that had very, very good patient satisfaction scores also talks about how, patients really love this model, and they really love being able to message their clinician. The next thing that I want to touch on in terms of telehealth tools is really the things that I put in this bucket here, which is patient is attempting behavior change, right? So there's a lot that I put in this bucket: medication adherence, diet and exercise, disease monitoring. There's a lot that we ask our patients to do to really be able to manage their own disease, right? And so self-management is a core component of chronic disease management. And just like communication, patient self-management, again, I think fits in that, the top right corner of our framework. So this is oftentimes sort of asynchronous communication between a patient and a clinician. And sometimes actually there actually isn't even any communication between a patient and clinician if they're able to entirely self-manage. So what this data here is showing is self-measured blood pressure monitoring. So remote patient monitoring for blood pressure is something that has lots of really, really good evidence behind it. And in particular, it is, it's an AHA recommended practice. And I think despite that, there's really, really low implementation, which I'll go into in a little bit later why that is the case. But what this data shows is that any type of self-monitoring, as long as there's either feedback or feedback in education and counseling, is associated with a significant decrease in blood pressure. So you can see the blue diamonds, the second, third, fourth blue diamond are statistically significant differences in blood pressure. But that top diamond, which is just self-monitoring without any type of feedback, is not associated with a significant change in blood pressure. In addition to sort of the self-monitoring for blood pressure, there's also a growing interest, of course, in mobile health apps. And so this study really looked at using mobile health apps to self-manage hypertension, and they do a meta-analysis. It looks like 10 or 15 studies. And again, you can see that diamond on the bottom shows that it is also associated with significant change in blood pressure. So I think there's sort of increasing data and recognition that digital tools, telehealth tools, can be really helpful for self-management and for improving clinical outcomes for when you're self-managing. I want to move on to thinking about telehealth tools for delivery system design. So this is, of course, the area where there's been a lot of interest and attention in the last 2 or 3 years. So virtual visits are, of course, asynchronous encounters between patients and clinicians. And there is, been a ton of interest in this. I think unlike the other examples, there's not as much data in the benefits of telemedicine. There are specific use cases where we have found it to be helpful. And so as an example here, this study, which was based in Japan, what they did was they compared in-person consultation or counseling for smoking cessation versus video-based counseling for smoking cessation. And what they found, you can see here, is that the abstinence rates at weeks 9 to 12, as weeks 9 to 24, were not significantly different between telemedicine or their control group, which is the in-person consultation. I think, surprisingly, it's north of 70%, which is, of course, very high for smoking cessation, but there's basically no significant difference between telemedicine and in-person care. Similarly, in this example, which pulled VA data, what they did was they randomized clinics in the VA system to either use a video consultation for diabetes care or in-person consultation. And what they found here is that you can see for the telemedicine consultation versus usual consultation, the in-person, there was no significant difference in A1C control. I think what they, interestingly though, you can see the systolic blood pressure actually went up in the telemedicine group and went down in the usual control. Sort of unclear what was driving that, but I think that sort of just goes to the point that at least for telemedicine, we haven't had as much time to really get the data to see how it impacts care, especially for chronic diseases and a variety of chronic diseases. I think what is much more clear from a lot of the telemedicine literature is that patients really like it. I think that's overwhelmingly the type of outcomes that have been published, which is patient satisfaction outcomes. And so this data, which comes from that same study, looking at the VA randomization of video versus in-person consultation for diabetes, what you can see is a couple of things. First is that the folks who had telemedicine consultation were just overwhelmingly more likely to be very satisfied with the visit, right? So 61% were very satisfied versus about 41%. And then the other thing that was interesting here is that you can see patients stating the percentage that disagreed that they benefited from the visit. So meaning that in the telemedicine group, 97%, 98% agreed that they benefited from the visit, in comparison to about 86% of the usual consultation group, right? So, for some reason, the folks who did telemedicine, they thought they received greater benefits. So patients certainly like telemedicine care. And to just go to that a little bit more, this is some quotes from patients that we interviewed at our health care system, which again is the safety net system in San Francisco. What you can see here is a patient talks about, like sometimes you make a trip to the doctor and you're not really happy about it because the attention isn't good. They don't touch you, there's no contact. And then those are the visits that don't require to examine the patient. So yeah, I think those are better via telemedicine. So really recognizing that there are times when telemedicine may be better and more patient-centered. Similarly, this patient talks about, it's more convenient. I don't have to wait. I don't have to travel to SFGH, which is our San Francisco General Hospital, our county hospital here. Transfer buses, it takes so long, I have to wait 30 to 45 minutes. So I think there's a lot of patients who certainly like telemedicine in specific cases. The last example of, of a beneficial telehealth tool I want to highlight is decision support. So in particular, what I want to highlight with decision support here are e-consult services. So this is where providers engage asynchronously to talk about, how to best move forward a patient's care. And this is often between PCPs and a specialty service, oftentimes to help address sort of access to specialty care, which is something that happens a ton in historically excluded population. So the first is that, e-consults, patients like it here. So thinking again about that quintuple aim, so care experience, you can see this patient says, well, if it's not something that specialist needs to physically examine me for, then why not expedite the whole thing and just have the doctor talks, right? So again, recognizing, similar to the telemedicine quote, that, if it doesn't require the clinician to physically see me, like, well, then why do I have to physically be there? And then this next quote I think is really nice and sort of highlights, the benefits of e-consults here is, this patient talks about, okay, well, I'm regurgitating the whole story of what happened. And then all of a sudden the clinician goes, okay, well, we need to order this test or that test. And so with at least e-consult, you can get things moving in motion. And then once the test comes back and the clinician says, yes, we should see them, we need a CT or this and that, then we can get it set up. It becomes a functional appointment, right? So this is a patient recognizing, like, well, it's a lot better if I go to the clinician when I need to get seen, and if there are things I need to do beforehand to make the appointment useful, then I'd like to do those beforehand. I think the other aspect of e-consults that has been helpful is that it is associated also with, lower costs. So if we look at this, so one thing, of course, the care experience I've highlighted in red here is appointments within 7 days. So this is a study that looked at a system that rolled out e-consults for dermatology. And they rolled it out for just a small group of clinicians and made it available for a small group of clinicians. And then everybody else continued to do what they called ambulatory referrals. So their traditional approach to referring to dermatology. And so between the e-consults and the ambulatory referrals, you can see folks were way more likely to get appointments within 7 days if they were in an e-consult group. And then I think interestingly, they were also way more likely to actually have completed appointments, right? So 60% in the ambulatory referral group completed their appointment versus 80% in the e-consult group, right? And the no-show rates are low in both. But when we think about just sort of making sure that there's not wasted time or wasted resources in sort of rescheduling appointments or having patients not show and the costs associated with that, we can see that e-consults really allow clinicians to capitalize on their in-person visits a little bit more. This paper too also talks to one of the other parts of the quintuple aim, which is clinician well-being. So you can see here PCPs in this study were asked how they felt about electronic referrals compared to prior referrals. And so this was in a healthcare system that rolled out e-consults pretty widely all at once. And what you can see here is that you can the overall care, about 72%, so that's a darker gray, felt like overall care improved using this e-consult service rather than the prior service. And this study that looked at the e-consult service for the dermatology program in particular, I thought this was really interesting. It showed that people who use the e-consult, so again the white bars here, had faster time to biopsy. So on the left side you can see the white bars smaller than the gray bar, and also faster time to definitive management for what was ultimately diagnosed as a skin malignancy. And both of those are significantly different, right? So this is, like time to specialty care is not just a process metric, it does often translate into actual time to diagnoses. Next section here, I just want to talk a little bit more about, I know this conference is focused on equity, so I want to talk about sort of areas where the digital divide comes up. So just to get a poll of the audience here, and then I'll respond to the question while folks answer here. Would love to hear people comment on what kind of barriers arise as they're thinking about delivering equitable telehealth. And if you're not in primary care, we could just think about equitable telehealth broadly, but would love to see sort of what barriers people worry about. And again, thinking about telehealth broadly, not just telemedicine, but really patient portals, e-consults, remote patient monitoring. What are sort of the barriers that people think come up? So okay, so I'm seeing a lot of patient is coming up as a big issue. I see sort of provider, some broadband issue, of course, and of course that like I think for folks who practice in rural areas, that in particular, I'm sure comes up a ton. Yeah, patient literacy broadband. Yeah, so a lot of the big things here. Funding. I see a LEP support. Great. So yeah, so the biggest thing I'm seeing come up here is patient literacy, and that is not a surprise to me. So I'm going to first start off with something that I think probably lots of folks in this room know, is that of course there's a lot of patient-facing barriers to telehealth. So first is of course having device access, and I don't just mean only mobile device access. I mean devices to if we're talking about remote patient monitoring, can they access the medical device, right? So devices to engage in any type of the digital communication or digital tool. The second is high quality data access and certainly also low cost data access. And so, whether that's cellular data or broadband data, that's sort of an issue as well. And then the third, which came up from the responses here, of course, is digital literacy. Like, do patients actually have the skills to do all this? And I'll go through the next couple of slides pretty quickly because I think folks are pretty familiar with this. But to highlight both the device and the internet piece here, this is some data from San Francisco when they did a digital equity survey. And we're obviously really close to Silicon Valley. And so overall, you see in San Francisco, overall, tons of people have smartphones with data plans. I think what is important to note here is that once you get into the lower income respondents and those who are older, not only were they less likely to have a smartphone, they were also more likely to have a smartphone with no data plan, right? So that maroon color is like a sizable portion of folks who had a smartphone actually didn't have a data plan. So, while it's great they have the device, if they don't actually have a data plan, they often can't capitalize on a lot of the benefits of actually having a smartphone. And access to the smartphone and the internet, I think one thing I want to highlight is that there are folks who have access to smartphone, have cellular data, but they're actually what we call smartphone dependent. So they rely they can use the internet, they know how to use it, but they're entirely dependent on their smartphone for internet access. And this is particularly the case amongst those who are lower income, younger populations of color, have lower educational attainment, and in rural, I think it's in rural communities. And the reason that's important is, of course, when you think about mobile data, it of course can often be throttled if you exceed data limits. And then there are costs sometimes associated with going above that, right? So, and then of course, if you're smartphone dependent, what you can do on your smartphone is not always the same things as what you can do on your computer. And so, as we think about digital health tools and employing them, it's really important to keep in mind if folks are accessing their internet versus on their smartphone versus a computer or desktop, and if they're smartphone dependent, like what is their actual access to like high quality, low cost data? And the data piece is important because there are like very, very clear structural barriers to broadband access. So there's a concept called digital redlining, which some folks might be familiar with, which basically talks about internet providers specifically choosing to not provide high quality, high speed internet in low income communities or communities with high proportions of populations of color. And this is really similar to the practice of redlining for home ownership in the past. So on the left side here, you can see that this is a map of the East Bay up here near San Francisco back in the 30s when they redlined certain districts to designate that these are the areas where populations of color, primarily Black people, were allowed to purchase homes. And on the right side is a heat map of access to the internet here. So this looked at the proportions of residents that had access to a high quality, high speed broadband internet. And the red and the orange are areas where there was like a low proportion of residential units that had access to high quality internet. And what you can see is these maps are pretty parallel, right? Like the sort of the areas that were redlined and populations that were excluded from owning, high quality homes in the past. Similarly, those same populations and areas have been excluded from having higher access to high quality, high speed internet. And these structural barriers matter because they are associated, we know, with like access to telehealth tools, right? So this is a study that very clearly shows that if the zip code has higher broadband coverage, there's just more people who actually use the patient portal, okay? And this is the case for, like a lot of our digital health tools. The last piece, of course, is digital literacy. And so in this same survey of San Francisco residents, they looked at who used the internet and of internet users who had basic digital literacy, which they defined here, you can see at the bottom, as being able to conduct an online search, find a website, send an email, or fill out an online form. And so in the dark blue are the internet users with basic digital literacy. So again, overall in San Francisco, 86% use the internet and have basic digital literacy. But if you look at the Latinx population, those with non-English language preference, older individuals, and low-income populations, they were not only less likely to use the internet, they were also less likely to actually have basic digital literacy skills if they use the internet. So I think just again highlighting, this aspect, the patient literacy aspect of the digital divide. And we surveyed our patients in our safety net system. So we called 200 of our patients who were scheduled for a phone visit. There's a lot of data on this chart, but I just want to highlight what's in the red box here. The first is, for our the participants in our survey. So almost 90% were identified as racial or ethnic minorities, and over 50% had a non-English language preference. And of this population, 66%, so like 2/3, were interested in a video visit, right? So there's high interest in this population, and over a half were able to complete a test video visit. And at that time, our platform used basically, and we still actually use Zoom. So it's actually complicated to get onto a test video visit. They'd have to be able to download Zoom and enter a personal meeting ID and make sure they can connect their audio. I think those of you who've provided tech support and know sort of the challenges potentially with using Zoom. But over 50% were able to complete a test video. I think what's important to highlight here, though, is despite this high interest, over 50% also reported barriers, right? So there was a lot of concerns about inadequate cellular data if they were smartphone dependent, or unreliable access to Wi-Fi. Some concerns about really hesitancy about using technology to address some of those literacy issues. And then there are also some folks who simply just didn't have access to devices. Okay. I want to take a moment and read this case briefly, and just would love folks to reflect on what are some barriers they're worried about to using telehealth. Here are some concerns they have. So a 49-year-old woman with hypertension, she's scheduled for a telemedicine audio only visit. So just a phone visit only for abdominal pain. So what are some maybe some concerns that jump out to people about this case? Yeah, so diagnostic errors, certainly. I'll give it another 20 or 30 seconds, and then if there's no other responses. Yeah, acute abdomen. Yep, can't do the physical exam. Mhm. Yeah, lots of really important points here. I think what lots of the sense I'm getting here certainly is that this is maybe a case like as a clinician that you would never really want to be scheduled as a phone visit. And so one thing here is sort of addressing sort of why was this case, why was this patient scheduled as a phone visit. And what I want to highlight with this case is I think this something like this, I think is probably not infrequent in certain health settings, and I think it just highlights that some health centers, we really haven't quite figured out how to implement telemedicine in a way that makes sense and is appropriate. And so this paper I think highlights that in that safety net systems here. So this is a study that looked at data from California safety net systems. And they looked at the types of visits that happened basically a year before COVID, and then like the initial 6 or 7 months after the public health emergency was declared. And what you can see in the blue here is that total number of visits, overall leveled out and actually went up for lots of places for behavioral health. And that was largely driven by audio visits, which is the darker black color here. The in-person visits in orange, went back up a little bit, but they certainly never went back up to baseline levels, at least in this data set here. And that video visits went up a little bit, but didn't go up very much. And I think what this is highlighting is, of course, that there are system decisions or system barriers related to implementing telehealth, telemedicine. So when I think about clinician-facing barriers, I think they largely parallel, to be honest, a lot of the patient barriers, right? So first is that the clinician and their healthcare system have to have access to appropriate devices. So I know in our healthcare system still, we don't have videos available in every single clinical room. And it's actually uncommon to have access to videos, right? So if we're trying to have people offer telemedicine visits, I do all my video visits off of my own laptop or my own smartphone. The second is that there's also a software piece. So it's not quite the data piece, but it's the software piece. So I'll share some data on this later, but we know that safety net systems, community health centers, are just less likely to have advanced EHR features, or sometimes software can be really expensive and it just simply isn't affordable or pragmatic for under-resourced centers. And then lastly, similar to sort of patients having to develop new digital literacy skills, the healthcare team also has a bunch of sort of new roles, new workflows, new skills that they really need to think about developing. So in the prior example, one is like really developing a workflow for thinking through how do you actually triage if something should or should not be a telemedicine visit, right? Other things include like learning how to do a physical exam over video, figuring out how to help provide navigation support if somebody has barriers to accessing digital tools. And just to highlight some of this data here, so this is a study from a little bit while ago, but it looked initially at EHR adoption. And so what they found here is you can see that smaller practices, public hospitals, and rural health clinics were just less likely to have gone live on an EHR compared to, for example, large group practices. And then if you look at the type of patients being served, you can see that those who had predominantly Medicaid patients also were less likely to have gone live at 2016, which is substantially about 5 years after the HITECH Act was rolled out, which is the act that encouraged encourage health systems to adopt electronic health records. And just to highlight how important it is for health system factors, this study looked at a setting in Boston, and they looked at predictors of in-person versus video versus telephone visits. And of course, they highlight the same patient predictors that we talked about before, right? Older individuals, populations of color, those with non-English language preference. But I think the big takeaway here from this study is that when they did a mixed effects analysis, they found that practices and clinicians accounted for much more of the variation in video visits, right? So practices accounted for almost 40%, clinicians accounted for about 25% of the variation in video visits, right? Compared to patient level factors. So, I saw a comment here thinking about like getting clinicians on board. I think that is so important that, a lot of the conversation about equity is focused only on, patient facing factors. And I think we need to think about really the multiple levels that drive equity. And so this article highlights different levels that impact digital health equity, right? So they talk about the individual, and we've talked about the healthcare system here, but there's also things that happen at the family and home, at the community level, and also the policy level as well. And so it's really important when you think about equity to think about all these levels of access. Okay. Lastly, I want to briefly just close out with a couple of takeaways, and then I want to hand it over to my colleagues for some case studies about what we did in our health system. So the first takeaway here is that I really want to highlight these digital tools are just tools, right? These do not inherently increase or decrease equity in any specific way. And I think this framework in particular is really helpful for thinking through that. So this is a paper that talked about informatics-based interventions and how they can generate inequities. And they say if you have a baseline health inequity, if there is unequal access, uptake, adherence, or effectiveness, then you're just sort of increasing the inequities. I think on the flip side, right, if you have a intervention that actually reduces inequities in access, uptake, adherence, or effectiveness, you can actually decreases the inequities. And this isn't theoretical. This is a paper that I think is a great example of how, a well-employed telehealth or a well-employed digital tool can really improve equity. So this paper looked at post-discharge follow-up appointments, pre-COVID and post-COVID, and what you can see in their red line is their white patients, and the black line, the blue line is their Black patients. And what you can see is pre-COVID, there's almost a 15 or 20% disparity in attendance at post-discharge appointments, right? But once telemedicine appointments were made available, you see the closing between that blue and red line. And it's actually regardless of whether the overall percentage of telemedicine visits were as low as like 25% or as high as 70%, right? So, this was a case where access to telemedicine helped address some access gap and help close the disparities in attendance at post-discharge appointments. The second thing, again, to highlight, right, is that it's important to think about equity challenges at multiple levels, right? So this is the same paper I alluded to earlier, and then they talk about recommendations at these specific levels. And so I want to just provide a really specific example from some of the work that I do. So I do a lot of work specifically thinking about home blood pressure monitoring. And you can think about sort of implementing self-measured blood pressure, the barriers that exist at each level. So right at a policy level, a lot of our patients, if they don't have a lot of sort of out-of-pocket money to be able to pay for their own blood pressure monitor, if insurance does not cover it, then that's an area where there's going to be unequal access. Similarly, at the community or societal level, a lot of times when we think about rolling out specific digital tools, for example, like an app to monitor their blood pressure, they may not be designed for all populations, right? So our clinic, over 50% of our patients have a non-English language preference, and very few apps are available in multiple languages. And so that is, again, a structural level barrier to accessing the tool equitably. At a health system level, as we talked about before, really making sure that the health system, for example, maybe has access to the necessary EHR tools or the personnel or data infrastructure to integrate the home blood pressure data with the EHR. At an interpersonal level, if patients, for example, are more socially isolated, they may not have somebody to help support them in either measuring their blood pressure or even sending the blood pressure data back to the clinical care team. And then at the individual level, right, there's health literacy, digital literacy, language barriers, many of the things we've talked about before. The third thing I want to highlight is just the importance of thinking about using implementation science tools when you implement digital tools to help ensure equity. So for those of you less familiar, implementation science is the study of how do we get known evidence-based interventions into the clinic, into patients' hands. So for example, this isn't the question of like, does the statin work? This is the question like, we know the statin works, but how come, only 50% of people who should be prescribed a statin are actually on it, right? So implementation science focuses on studying that second question. And in particular, it uses a lot of frameworks for helping us think about how we can encourage behavior change or how we can encourage intervention adoption. So I just want to highlight one example here is the Combi Framework, which thinks about sort of the capability, the opportunity, the motivation, and the behavior necessary to result in behavior change. So again, drawing from the example of home blood pressure data here, we've interviewed some clinicians and some patients and asked them, what are some barriers to collecting home blood pressure data, which again, earlier we talked about that really being an evidence-based practice and guideline recommended care. And there's a bunch of barriers facilitators that have come up, but I just want to highlight a few for which we have quotes. On the capability aspect here, you can see this a clinician says, if there were rigorous training and we knew what patients were being asked and patients knew what to do, it might be helpful. On the motivation aspect here, one of the important things is, of course, like how motivated the patient is to measure their blood pressure. And so this patient here says, I'd be happy to send in that data because the doctor will help lower my blood pressure. You can't play around with blood pressure. That could bring fatal results. And then within the opportunity bucket, there's a lot of things that come up in here. But in particular, I think something we've alluded to is really the importance of thinking about like the workflow and making sure clinicians and clinical teams are really supported when we talk about rolling out telehealth or rolling out any digital tool. And so you can see this quote from a clinician who says, that's always the concern. When we're getting more information, what are we going to do with that? Do we have a plan in place? If somebody emails us and their blood pressure is 200 over 150, do we have a good plan in place to address that immediately, be able to help and support the patient to get the care that they need? The other framework that I want to briefly highlight here is the REAM framework, which focuses on the reach, efficacy, adoption, implementation, and maintenance. And I think this is really important for those of you who are in positions to really think about measuring equity, using this framework to think about equity in a variety of ways. So like the reach, which proportion of the patients, for example, are having access to telemedicine visits? The adoption, is this being adopted in all clinics by all clinicians, in all of our healthcare settings? Implementation, how is telemedicine is it actually being implemented the way that we want it to, right? So, we want video visits to be happening with an interpreter in the video visit, but like how often is that actually happening, or is it actually ending up being a phone visit? And then the maintenance, really, so oftentimes when we roll out new interventions, there's really high adoption initially with the first month or two, and then afterwards adoption drops, right? So making sure you think through, okay, 1 month out, 6 months out, 12 months out, is this still available and accessible to everybody the way that we think it is? And then lastly here, I think there's a lot of folks in the room here, but there is, I think, a role for all stakeholders here, right? So whether you're a member of a clinical team or you develop technology or you're an advocate to policymakers or payers or you're in the research community, I think there are things that everybody can be doing to help improve telemedicine or telehealth equity. Okay, so I want to move into the case studies here. And of course, we'll hopefully have some time for some questions. And I want to highlight in our case studies, we do a little bit of groundwork and then pass it off to my colleagues here. I'm going to briefly introduce them. So with us today, we'll have Dr. Delphine Tuot, who is our Associate CMO for Specialty Care and Director of our Center for Innovation and Access and Quality, and then Dr. George Su, who's our Medical Director of Telehealth. So I'm going to set a little groundwork and then pass it off to them. So as we talked about, there's a lot of factors that impact equity. And what I want to highlight in this example here is a case study of like how we at our health system have been thinking about a variety of these factors. I want to start off first with thinking about, what we'll talk through is what we've been doing for at a clinical level, so things that clinicians can do related to offering it to every patient and screening for barriers and connection to resources. And then of course, folks can advocate to policymakers. And also at an organizational level, we'll also highlight organizational decisions people can make sure that their tools are as accessible as possible to historically excluded populations. So just to give you some context here, our health system, if I can get my slides to go, is we're the safety net system for San Francisco. So on the left here, you'll see in our primary care, we primarily serve Medicaid and Medicare insured individuals. That's over 75% of our patient population. In that other bucket, that 15% is folks insured by Healthy Workers, which is basically a county program to provide healthcare access to folks who are in-home caregivers for our Medicaid insured individuals. And then in terms of racial ethnic diversity, on the right, you can see that overwhelmingly we serve populations of color. Almost 40% are identified as Latinx. We have a quarter Asian, and then 15% Black and 15% white. And amongst those folks, you can see educational attainment. Overwhelmingly, folks, are in the sort of high school group or less. So, this is a pretty vulnerable population. And just to provide you a little bit of context of how we've been implementing telemedicine, we went live on Epic, which is a large EHR, just a couple months before COVID. And so that has overlaid into a lot of our journey in trying to make telemedicine equitable. We were really folks were still just getting used to using our new EHR. And then we needed to start having telehealth visits, which we did over Zoom initially and are still there, but we're transitioning soon. And then we didn't actually even have a telehealth visit type in our EHR until June. And then we put out an RFP for an integrated video client, which Dr. Su will go into a little bit later. And sorry, just 2 more slides, I'll pass off Dr. Su. The first thing to highlight again is sort of pre-visit is that it's really important to really screen for patient barriers to telemedicine, right? So making sure that your healthcare system or your setting has questions for screening for device access, data access, and then also digital literacy access. And it can be helpful to have really sort of an open question that, ask folks if they have any other concern about their visit. And then once you're screening, it is not helpful to screen if you don't have a plan on what to do with the screening. So, once you screen, thinking about like how you can connect patients to resources. So in California, there's a Lifeline program. A lot of the states also similarly have a Lifeline program for devices and also data. The National Digital Inclusion Alliance has great resources for low-cost device and internet access for folks. And then the digital literacy piece, I think, is really an area where there's a lot of interest and research in trying to understand how best to support patients with literacy. In our health system, we've done things like connect with local libraries, develop an internal support program that Dr. Tuo will cover. And then we've also tried to make videos accessible to patients in multiple languages. So I'll go ahead and hand it over to Dr. Tuo.
Great, thank you, Elaine. So I just want to highlight a little bit of work that we have done in the last year or two to try to increase our video visit use among our vulnerable patient population. So just to set the screen, sort of before this telehealth ambassador program that I'll talk about started, we created workflows to try to screen for interest and barriers to telehealth, as Elaine or Dr. Kuhn just mentioned. These are example scripts that you see. These are a little bit wordy, although we tried to condense it as much as possible for our front desk clerks, for our medical assistants and nurses to use, as well as for providers to use. Next slide. We also tried to advertise video visits are here, right? Even though we were using Zoom and our technology was a little bit clunky, we wanted to try to encourage patients and their caregivers to really ask for a video visit when they were excited about that. So you see here an example, nice bright colors, bold statements, easy to read, low literacy, both Spanish and English, as well as Chinese. Next slide. And then in our after visit summary for every ambulatory care visit across the network, we had this little, again, blurb at the bottom, really saying, hey, video visits are here. Go ask your provider. This is a website that you can go to where you can see how to download Zoom. And that was in a multitude of different languages, thanks to Dr. Su and his colleagues. Next slide. Nevertheless, despite sort of giving some tools to our clinician teams and giving some tools, albeit rudimentary for patients, video visit remained low. Patients were still uncertain that clinics were offering video visit and they didn't ask for it. Caregivers and younger family members who might have better experience with video visits or telehealth in general just weren't asking for it. We found out from observations that staff were not comfortable offering video visits or onboarding patients onto Zoom. Many of our staff actually mirror our patient population and don't necessarily have the comfort level using the digital tools that we expected. The benefits of video over phone were not always obvious to staff either. And so really explaining why should we spend our time really trying to get our patients onto video was a bit of a challenge. And then lastly, the COVID pandemic sort of hit us just as it hit many other health systems and created lots of staffing shortages. And so there was no time for usual staff to help patients bridge the digital divide and with technology challenges. Next slide. So with this context, we created a telehealth ambassador program, which is a volunteer program. We leveraged initially second-year medical students as team members. This was part of their QI curriculum as a second-year medical student. So we tried to make that curriculum a little bit more robust with roles and responsibilities on offering video visits to eligible patients, screening them with the digital screening tools and questions that Dr. Kuhn mentioned earlier, helped patients get onto the Zoom platform. We worked with the students to try to identify inefficiencies with the process. They learned about lean and learned about quality improvement strategies in the process. So this was also a QI learning curriculum for the students. Next slide. In the process of a couple months, we tried to contact about a little over 770 patients. We only reached about 50% of them. Among those 50% that we reached, about another 50% sort of declined the service and didn't really want the Zoom onboarding process. Of those, most of them didn't feel like video visits added value over phone. Many patients did not have access to a device. They were hesitant to learn the new technology, even if they said they had a smartphone in front of them. And they voiced that they didn't have time to actually go through that process, even when offered to be contacted at a later time. And so at each cascading step along the way, contacted, reached, successfully onboarded, and then actual video visits completed, in the end, only about 13% of patients had a very successful video visit. Next slide, please. So the lessons learned, just very briefly, we learned many, and we're trying to incorporate some of those lessons in our second iteration of this, is that patients are hard to reach by phone, right? We only reached about 50% of the people that we tried to contact. We know this when we're doing reminder calls for our patient visits as well. So there might be an opportunity to leverage text messaging, which many patients have already identified as being an easier way for them to communicate with the clinics. Patients are more likely to try video if arranged by a staff or a provider, not necessarily somebody who is not connected to the clinical enterprise. And so trying to embed the video visit offering within the clinical workflow is the opportunity that we should try to leverage. We've created a referral to a telehealth ambassador pool. So now all clinicians can refer patients at point of care to get this type of onboarding. Among the 13% that actually did have a video visit, they were thrilled, very satisfied. So post-visit surveys, telephone surveys with those patients were extremely satisfied, and that was really gratifying to hear. And that we can provide that reinforcing feedback to clinicians and clinician teams, really highlighting that yes, there is a benefit to video over phone. And then lastly, volunteers, which this program was essentially based off of, don't really have EHR access. They don't have scheduling capabilities. Those are limited functionalities. And so we really need to partner with this more stable and sustainable workforce that has those capabilities to make this program more robust. And then integrating this program with MyChart or with patient portal access is going to be really key to try to just increase digital literacy overall among our patient population. I'll stop there.
And then I'll pass it off to Dr. Sue to just talk a little bit about some of those organizational aspects that folks can do to really think about how to make sure telehealth resources are available equitably.
Thank you, Dr. Kum. So, as Dr. Kung mentioned, that we have recently adopted or moving toward adopting an enterprise video platform through our electronic health record, Epic, and we had many lessons learned from our previous years of using Zoom as our preferred platform, and some of those lessons were explicitly put into our requirements for our RFP, and some of those are listed here. So number one, we insisted that we had no application download for the patient. So the technology here is called web real-time communication. The solution would be also outside of our patient portal as a way to contact our patients with this. And the solution was that we would have a text link, a true SMS link to the patient, whereby the patient could click on that link, and the invite would automatically open a window for the patient to communicate with our providers. We also require that an ad hoc text link be able to be sent to our patients. And then part of what we were creating was also a system so that we would have structured field in our electronic health record to document digital literacy and issues, similar to what we would do with social determinants of health. Next slide, please. So for the patient, this is what our platform, this is a mock-up of a wireframe of what our patients would see. So this would be, again, an SMS link, text link, and we're currently editing these to make the wording a little less intimidating, but the link would then open up a video visit again, without the requirement for downloading an application, and immediately launched the video visit window. Next, please. And as Dr. Kung mentioned, one of the primary barriers for us really was on the provider side. And so we insisted that the experience be seamless for our providers, that the entire platform be integrated into the electronic health record. And from a systems hardware standpoint and workstations, we are designing the system to have video available at each workstation. Next slide. Work done by Anjana Sharma, who I believe is on this call, showed that our providers looking between telephone visits and video visits would expend an inordinate amount of time, more than a quarter of them, over 10 minutes, navigating the technology to manage video visits. And as we might imagine, this would be enough to completely or have our providers abandon those visits altogether. Another reason why our uptake has been so low. So again, we were very intent on making this experience seamless as possible for our providers. Next slide. Examples of how we did this. So this is a scheduling view from our electronic health record in Epic. Everything, including multiple icons under the video column here, would show the provider connection status. From the same line, we'd be able to send a link to the patient, open a visit simultaneously. And we're also, our first iteration in our system here is to use tablets, iPads that would be located at each individual station, and we'd be able to send that video to the iPad. Next slide. And so those are broader strokes around how our system is trying, again, through the technology design of the platform, video platform itself, trying to narrow some of those equity gaps, disparities that we see with the use of the technology, and also doing our best to try to bridge some of those gaps for our providers as well. This particular use case is through the lens of a directorship of a clinical program. And this is the management of obstructive sleep apnea. I also happen to direct our sleep program here at San Francisco General Hospital. Next slide, please. So positive airway pressure therapy for obstructive sleep apnea, there are lots of barriers to achieving care equity. There's poor adherence to positive airway pressure therapy, which is exacerbated in our safety net population. The devices that we use are often complex, very difficult to use, invoking challenges with patients with digital and technology literacy, lesser literacy. Resources are often in English only that are available on the web or in print form. Our patients tend to be less able to troubleshoot on their own or to come to clinic for in-person visits, citing childcare work, travel demands as examples. And telehealth technology, we thought could offer some opportunity to narrow these care gaps. But as one of our posters noted, but these may exacerbate them as well. Next slide, please. So this is an attempt to describe some of the leveraging of remote patient monitoring. I know this discussion has mostly been around video visits to this point, but the devices we use do have connectivity to networks through cellular networks. This is a study just showing a survey of persons using these types of devices and access to Wi-Fi or Bluetooth or cellular. Cellular access distribution was much higher for these persons, whereas Wi-Fi was less and Bluetooth offered a good connectivity solution. However, it was considered a technical barrier for most of these patients. Next slide, please. For our patient population, this is just showing the dashboard with these devices. And so we very explicitly asked our durable medical equipment company to purchase devices that used cellular network connections only. So we didn't want to invoke some of the challenges that some of our patients have with Wi-Fi or even Bluetooth. But as you might be able to appreciate here, these are all individual patients. There are boxes with M's, which means that the devices still are being monitored, but the data is not being transmitted. So again, even with our patient population and most of our patients using cellular networks for their phones, we still have gaps, and we appreciate those gaps within our patient population. Next slide, please. A comment on the FDA and usability engineering for these devices that we see that are FDA approved. Really, the FDA approval process focuses on safety more than usability. And so our devices, next slide, please. These PAP devices do indeed, as some of you may know, have problems and issues with usability. So this was a study done in a patient population that has a much higher educational attainment level than our patient population, with 10% high school graduates, 40% college, and even 20% with a 4-year college degree, saying that they could easily connect the tubing, but no, they had trouble adjusting controls and adjusting the mask itself. And in fact, here, using what's called a use-PAP score of usability, showing that clinical outcomes, which would be night reduction in PAP use, was compromised by worsening of usability. Next slide. So how we address this, we leverage telehealth and video visits. So video visits proved to be a very effective tool because of the visual capacity of our patients to see what our respiratory therapist is advising them to do, and the reciprocity of the patient showing their device and how they're using the machine or not using the machine correctly, again, proved to be a very, very effective tool for us. Next slide. Here, our respiratory therapist is showing how to use the device itself, showing how the buttons work, and putting on the mask itself. Next slide. So our solution to mitigate barriers to equitable care for obstructive sleep apnea included, again, passive remote patient monitoring. So we wanted a solution that would require no manual data downloads, such as to data cards. We insisted that we had universal distribution of devices that use cellular networks as opposed to Wi-Fi or Bluetooth. And this was our Medi-Cal, our California Medicare provider, and insisted that our DME contractor get these devices, even though they were a little bit more expensive. We explicitly acknowledge that the devices that we distribute are designed with safety as a priority and not so much with usability in mind. And in order to compensate for those usability defects, we had to invoke human resource, in this case, respiratory therapists, to mitigate. Video visits are indeed an effective tool for, in particular, for PAP, positive airway pressure troubleshooting. However, as Dr. Kung and Dr. Tuo described, this really in our system requires a dedication of resources and time for the video onboard. Thank you.
Great. I just wanted to thank, collaborators, some funders for some of the studies that we cited, and be happy to take questions. I know we just have a little bit of time.
I'm really appreciative of this presentation. It was great to have a lot of that data that we were looking at. It's very informative to me, and I'm going to go back through some of the studies that you guys cited and read through some of those, because I saw a lot of really interesting things in there. In the chat, we do have a couple questions, and so we can look at a few of those. And so one of them is based around, the idea that I guess it was just more of a comment that, people experience telemedicine for the first time sometimes after COVID, and it was a rushed kind of had to make it happen sort of. Do you think that has an effect on people's reluctance to continue telemedicine now? The telemedicine we got right after COVID hit may not have been as high quality and may not have been as well thought out as what we are able to offer now. Do you think that may be one of the reasons we're seeing a slow uptake in it?
I'm happy to answer, and if Delphine and George want to jump in. I think a couple thoughts. Yes, I think certainly how you roll it out initially, I think with any type of digital tool, like the first time you introduce an intervention, like if it's a poor experience, like you have to do extra work to get people back to trying it again. When I think about our health system, for example, we rolled out audio only visits as the default. And like, I think we're fighting an uphill battle to get like patients and clinicians to feel like, okay, it's, we should be trying video visits, right? Because they feel like, well, phone visits are working. Like, why do I need to put the extra effort in to make it a video visit? So I think that's certainly important. One is that it's important. Two is, yes, I think telemedicine numbers are down. I don't know if that's like inherently a bad thing, right? Like, I don't think anybody thinks that like the 80% of visits that were telemedicine immediately post-COVID is like where we should end up long term. So I think, telemedicine rates going down, like, I'm not sure what to make out of it, because I don't think we know what the perfect mix is in terms of this hybrid model, right? Like, is that 10%? Is that 30%? Is that 50%? It's probably really dependent on the patient population, the type of care that you're providing. So yeah, those are sort of my initial thoughts on that comment and question.
Yeah, I'll also just add, I think it's all about precision medicine, right? Like, we want to make sure we want to use telemedicine as a way to provide the right care for the right patient in the right time. I think we all abide by that. Trying to figure out what that sweet spot is, I think, is going to be a challenge. But I think offering telehealth visit, giving providers the opportunity and using tools to try to identify when telehealth is appropriate and when is probably most appropriate, I think is our next step as we try to roll out our next version.
Yeah.
And I would just comment that, at least anecdotally here for us, we found that our patients actually, because of the pandemic, were more facile with video technologies, contacting, conversing with their families over FaceTime, for example. But to Delphine's point, a lot of our medical specialties are still trying to wrap their arms around what's an appropriate use for these video technologies. Again, to that point about precision medicine.
I think
add one more. Oh, sorry, go ahead.
Good question in there about wearables.
Oh, yeah. Let me just say one more comment, and then I'm happy to try to answer the wearable device question. I think one thing is like sort of the precision medicine piece is that, like, I think like our payment model gets in the way, I think is the reality, right? Like, I at least as a clinician, I think all of us want to provide the right type of care to the patient at the right time. But if it's not reimbursable, then that is a huge factor that comes into play, and I don't have great solutions on that front. But I think that's sort of like a pragmatic consideration that really impacts how we ideally think we want to deliver telehealth. In terms of the promise of wearables, yeah, I think that sounds that sounds great. I think there's not a lot of great data on wearables as far as I know in terms of like clinical outcomes or anything of the nature. And I think I even saw a paper that like people who wore Fitbit actually exercised less because they were exercising more than they realized, so they felt like they didn't need to exercise as much. So I think we're reaching an age where there's like a lot of opportunities to collect a lot more data, and I'm always all for more data. I think what we do with that data and how useful it is, I think is sort of an unknown. And then the other thing that I certainly worry about with sort of biometrics and wearables is we just think about equity, right? Like, we see all the studies right now showing that like pulse oximetry rate is really inaccurate in folks with like more melanated skin. And so I just think about sort of making sure that these wearables, we know that lots of technology devices initially just aren't designed for diverse populations. I think, the VR headsets initially, actually, when they rolled them out initially with women, they were just like way too heavy because they tested them all on like the male software developers, right? Like something as simple like that. And so that would be just my hesitation with a lot of these devices. I think you really want to make sure that they are validated in all populations.
Yeah, maybe I can comment. Elaine just had comment on validating. So oftentimes these wearable devices because of FDA approval restrictions, the companies decide to take the direct-to-consumer route. So we have a lot of data out there that is not necessarily validated. It may become over time, but many of these platforms are not FDA approved. But having said that, one of the challenges that we're already facing is trying to how do we incorporate that data? How do we filter that data? Companies have made great strides in filtering some of that data and limiting some of the noise. But on top of that, the medical system still needs a way to bring in that data, codify it, document it, and then have an effector arm to do something with that information. So that's going to be a really big challenge for us.